Okay, next up, we have Senator Holmes with Senate Bill 9 with Senate Committee Amendment number 1. I'd like to adopt the committee amendment. Senator Kaler moves that we do adopt Senate Committee Amendment number 1 to Senate Bill 9. Is there leave to adopt the committee amendment? With leave being granted, the amendment is adopted. Now, Senator, before you describe your bill, I'm going to take a look at our witness slips. We have 1,115 proponents, 881 opponents. We will enter all those into the record. We are going to take testimony from 3 witnesses, 3 proponents, and 3 opponents. And we will get to them in a moment. But Senator Holmes, please. Oh, I'm sorry. There's a motion to open the roll. Senator Castro seeks leave to vote. Oh, Senator Castro moves do pass as amended and seeks leave to open the roll and vote aye. Thank you. Senator Holmes.
Thank you so much, Mr. Chair. This bill has gone through much discussion and many amendments, making some of the allaying certain concerns on this. I want to talk a little bit, though, about what exactly the bill does. Very simply, this allows an adult, 18 or older, if they are diagnosed with an illness, a terminal illness, and they have less than 6 months to live, and they are mentally competent to make an informed decision, they will have the option of being able to get a prescription that they may choose to take that will end their lives and end the suffering. There are well over 20 guardrails in this bill to make sure there are no instances of coercion. Nobody can be forced to do this. Many of those safeguards have to do with the patient themselves is the one that has to request it. The patient needs to request it of their doctor. That doctor then also has to feel that they are mentally competent to make this decision. They then see another doctor that confirms the diagnosis of less than 6 months to live. If either of those doctors has any concerns whatsoever that the person is not mentally capable of making an informed decision, they are then referred to a mental health care specialist to make that determination. That all has to happen before this goes into play. They must submit, they make a verbal request. In no less than 5 days, they have to request again. There's a written request. It is witnessed by 2 separate witnesses, one of which cannot benefit off the person dying. That's why we have put so many guardrails in there, because this is such a personal and difficult decision for people. Nobody wants to end their lives. However, they also don't want to suffer. Why did I decide to introduce this bill? Like so many people that I found once I did introduce this bill, and I have heard countless stories, and it's these stories that have made people understand why this is so important. When I was 15, my father was diagnosed with lung cancer. He was diagnosed in September. He died in January. A mere shell of the robust, vibrant man who was my father by the time he passed away. And the pain of that cancer was incredible. That loss was tough. And we kids in that household were then raised by my mom, who said that she wanted to make sure that if something ever happened to her, there would be no prolonging of any of her suffering if she was to have some kind of illness like that. Unfortunately, in 2016, at the age of 82, my mother was diagnosed with pancreatic cancer. Like lung cancer, it's one of those very, very painful cancers to die of. With the diagnosis of pancreatic cancer, she was given 3 to 6 months to live. That diagnosis came in September. She died in mid-October. And the reason I tell you what their prognoses were and when they actually died was so many people say, well, doctors, are they necessarily going to be accurate? do people really, what if they would have really lived much longer than that? Doctors typically want people to have hope. So it's very rare that you're going to get a prognosis that's going to give you longer than you're actually going to live. And if you are living longer, you as the patient with that drug, you decide when you want to self-administer it. I will say that for most people, that comes within usually what would be a couple weeks of them dying. And I will argue that it is palliative care in the sense because you have this drug and you know that should the suffering become unbearable, you have the option to take it. So you wake up one day and you say, no, I think I'm okay today. I'm not going to take it. Fully 37% of the people that have this drug in their position do not ever take it. This is not something that somebody runs out and gets a diagnosis of 3 to 6 months to live and immediately gets the prescription and runs right out and takes it. Are there other states that have done that? Yes, there are 10 other jurisdictions: California, Colorado, Hawaii, Maine, New Jersey, New Mexico, Oregon, Vermont, Washington, and Washington, D.C. This began in Oregon in 1997. So we have decades of data that we can look at. In all of those decades of data, there have not been any cases of coercion or abuse of the ability to do this. And part of it is because of all those guardrails we have in it. Some of the arguments you're going to hear are things that this bill really doesn't do. We have heard that and I will put it in quotes, the disability community, because I would say the community as a whole, you really can't classify it that way. And the reason I say that is because there have been so many studies being done, and I want to read you just a couple of the stats from that study. This was a study done by 700 people by Impact Research, and in those people that they interviewed, those who self-identified as having a disability, I have MS, so I have a disability, it means nothing to this bill, simply because I have MS or any other disability, unless I have a terminal illness that is saying I have less than 6 months to live. The fact that I have a disability is totally irrelevant to the bill. 73% of those who identify as having a disability support this measure. People need to realize that it is over 70% of people as a whole that support people having the option of medical aid in dying. It doesn't break out in any certain ways by race. 69% white or Caucasian, 69% black or African American, 86% Hispanic or Latino. Doesn't break out by age. It's still always over that percentage. 18 to 49, 75%. 50 to 64, 68%. Those that are 65 and older, 62%. Also by religion, which is a lot of things that people would be surprised because different religions may have views on this. However, again, you cannot lump all these people together. 69% of those who identify as Catholic are in support of this. 58% that are Christian but not Catholic, and 89% that are agnostic or not affiliated with any certain religion. And as I started doing this and I started talking to people and reached so many people and heard so many different stories, and I found out, you know what has somebody that comes to the terms and says that they are in favor of this bill? It's lived experience. It is as so many of us have had the unfortunate experience of watching somebody we love die. As the baby boomers started losing our parents, we saw what that death could look like. Is it horrible to lose your mom and dad? I mean, as a 15-year-old, to lose my father was devastating. Losing my mother, who of course then had raised her 4 children, was really, really hard. And we were so close, as so many mothers and daughters are. But as hard as it was to lose my mom, the worst was watching her in pain. You just cannot see somebody you love suffer. So what does this drug do? This drug means that you have that option to not suffer. I'm going to push back really hard on those people that call this assisted suicide. It is not suicide. Quite simply, these are not people that want to die. These are people that are going to die. Certainly, my mother did not want to die before she watched her grandson graduate from college. He graduates from law school in May. Mom would have loved to have been here to see this. She did not have that option. I will also tell you one of the problems is you take drugs that are supposed to help you not go through this pain. What people don't tell you, what so many people witness as they watch somebody dying, is the breakthrough pain that drugs cannot control. That is a very real, I saw it myself with my mother. That made it very difficult. There's also studies showing right now that there's going to be a problem getting some opioids, so that's going to be a problem even in trying to control the pain. I'm going to give you a few facts. The death certificates of people who use medical aid in dying do not list medical aid in dying. They list the disease. Had my mother had the ability to take this and done that, she would not have died because she used medical aid in dying to end her suffering. Her death certificate would say she died of pancreatic cancer. This is very important for a couple of reasons. Number one, in our family histories, we want to know what people are dying from. So this makes that very, very clear. Also, insurance companies, this is not like suicide where they may not pay out benefits or you may be fighting or waiting for benefits, because this is not going to impact your insurance. I'm also going to argue that this is palliative care. By the way, when that doctor diagnoses you, they also have to offer you what your options are. There's palliative care, there's hospice. So all of those options, there's pain management, all of those are given to you along with the option of medical aid in dying. So you have all those options, and they are forced to tell you that, and it's all documented that they have. I'm going to let some of our witnesses talk to you, and we're going to hear from people on both sides of this issue, and I know it's a personal issue. It certainly is extremely personal for me, watching my parents. It's also very, very personal to some of the witnesses we have here, and I'm sorry that Deb, who was sort of the person we wrote this for, we call it Deb's Law, she has a very rare form of cancer, and she has been alive now for 2 years, unbelievably, because she's one of those who wasn't expected to live that long. But she has dedicated her life, and she was here to testify to really trying to make sure that this happens so that it is an option for her and other people that have the form of cancer that she has. Unfortunately, she is undergoing an experimental treatment, so she is unable to be here to testify. The last thing I want to do, though, before we introduce some of our witnesses, is just ask you one question. If you're totally opposed to this, and that's fine, because we all come from our own personal experiences and our own backgrounds and everything that shapes us, you have the choice, obviously, to not use it. Just because it's available doesn't mean it's an option. You don't have to take it. I would never dream of telling you you should choose medical aid in dying if you don't want to. And I guess that comes to my question. Why are you telling me that I don't have the choice should I want to? Why don't I have that choice if I'm going to die of cancer or ALS or some other disease where the suffering has the potential to be unbearable? I think I deserve to make that decision for myself. Because let's face it, at the point you're giving a diagnosis like that, pretty much you're feeling like your decisions have been taken out of your hands. Why not have this one? So, thank you.
Thank you, Senator. We'll go now to testimony from proponents. Why don't we start with the proponents we have here present? If you can go ahead and identify yourself for the record and then proceed with your testimony.
Good afternoon. My name is Susie Flack. I'm a lifelong resident of Illinois and recently retired from a career as a special education teacher. I am here today to share the story of my son, Andrew, who utilized his right to medical aid in dying while living in California. In 2017, Andrew was living the dream. He had moved to California, finished his master's, and was continuing his career as a special education teacher. Andrew sought medical intervention because he was feeling unwell, and within days he was diagnosed with stage 4 colorectal cancer. When Drew called to tell me his diagnosis, I immediately pleaded with him to return to Illinois for treatment. But Andrew was a very optimistic young man. He was convinced that his treatment would follow a similar course to the treatment he had when he was 4 years old, undergoing cancer treatment for Wilms tumor. And so he opted to stay in California. And this is how his journey began. Initially, he underwent many types of chemotherapy and several bouts of radiation. During a surgery to remove the tumor, it was discovered that his cancer had spread to other vital organs. In spite of this setback, Andrew did not give up. He remained positive, applied for medical trials, started immunotherapy, and had all gold standard treatments. All this time, the cancer continued to ravage his body, and it was very difficult supporting Andrew from afar. I'm very thankful that our family was financially able to take turns and go out and support him during his time with cancer. However, there were many times when Andrew spent nights alone in the hospital, and that's a very lonely place to be. Thankfully, Andrew had an amazing support team of medical professionals. During one stay in the hospital for an infection, Andrew's doctor informed him that his cancer was terminal. My baby heard these words alone. It's something that will forever haunt me. Luckily, his doctor spent hours with him discussing his end-of-life options, one of which was medical aid in dying. The next day, Andrew called to inform us that his cancer was terminal, but I pleaded again, please come home to Illinois where your family and friends are. At this point, he said hardcore no, that he wanted to remain in California where he had this option of medical aid in dying. Andrew prayed he would die in his sleep, but his will to live was so strong. His body, although it was ravaged, he continued to fight. He explained in detail how having this option was very important and comforting, and it allowed him to have some control over his death. As he fought the cancer and the side effects, his body continued to decline. Still, my optimistic son did not give up. He started a podcast entitled Death with Dignity and advocated for end-of-life options. My son woke up each day with one goal, and that goal was to make it through the day. The term assisted suicide is extremely misleading because my son wanted nothing more than to live. The horrible side effects happened, and just his quality of life continued to deteriorate. And he drew lines in the sand. When this horrible thing happens, I will use the medication. And those horrible things did happen. And he continued to get up and strive for one more day. The medication sat in the fridge for months because his will to live was so strong. In spite of having Gold Star treatment, including palliative care and hospice, Andrew's pain became intolerable, and his quality of life consisted of sitting precariously on the couch to avoid the open wounds that the treatments had given him. On November 16th, Andrew woke up and said, "I think I'm ready." We had a wonderful day watching TV, playing board games, having a family Mario Kart tournament, which Andrew, of course, won and was crowned the king of the world, a title he will always retain. At sunset, Drew's sister, his dad, his roommates, myself, and Jackson the dog followed him into his room. Drew was a lover of music, and he had composed a playlist special for this day. As we listened to the Beatles and Tom Petty, we shared our favorite memories of Andrew. The sun set, and it was a beautiful evening. Soon the hospice nurses came in. They had mixed the medication with raspberry sorbet, and Andrew had not eaten for days, and he just devoured that raspberry sorbet. I thought they would have to wrestle him for the spoon. Within 2 minutes, my son was snoring, which was music to my ears. He had not slept soundly for years. And he took his final breath 2 hours later, peacefully. His death was a beautiful thing, just like his birth. I urge you to vote for this tried and trusted bill so that others do not have to follow the same fate as my son, and make Illinois a leader in the medical aid and dying community. Thank you.
Kadeen?
Hello, everyone. Kadeen Bennett with the ACLU of Illinois, speaking in support of Senate Bill 9, Senate Amendment 1, now called Deb's Law. Our interest in this issue stems from our historic commitment to bodily autonomy, and in this case, our support of a person's right to use or refuse treatment.
I'm sorry, Kadeen, can
Oh.
I just stop you for just a
Yeah.
minute? Senator Sims seeks leave to vote. I'm sorry, Kadeen.
Oh, please, no, all good. A person's right to use or refuse treatment and their ability to access the full range of end-of-life care options, including comfort care, pain control, palliative care, hospice care, and aid in dying care. We want people living with a terminal diagnosis like Deb Robertson, who this bill is now named after, to have the full range of options available at the end of their lives. To that end, we partnered with Compassion and Choices to draft legislation that incorporates the approach that has been foundational in other states and reflects lessons learned over time. Some of the testimony you may hear in opposition to Deb's Law focuses on concerns raised by some of the ACLU's allies and friends in the disability rights community, organizations that ACLU has worked with, including on current litigation, to assure that people living with disabilities have the choice to live in the community and make their own decisions about healthcare. Some of those concerns reflect fears of coercion or abuse of people who are living with disabilities by family members or based on their history of experiences with aspects of the medical system. Understanding their historic opposition and our understanding and agreement that aspects of our current healthcare system is broken, we reviewed concerns and arguments raised by disability rights advocates and included protections we hope could address those concerns. After drafting and before filing legislation, we met with members of disability rights organizations to go through the language and learn more about their concerns and solicit input on additional language that can make the bill stronger. We continued the outreach even after the bill was filed last session and remain open to suggestions. While we respect all voices in this debate, we believe that the movement for bodily autonomy for everyone, including those living with disabilities, must now include a full range of options when one is facing a terminal medical diagnosis. Senate Bill 9, Deb's Law, advances bodily autonomy and strikes the right balance that allows for access to this needed and requested end-of-life care option while including critical guardrails that protect anyone being or even feeling strong-armed by others into making a choice that is not their own. Thank you.
Thank you. We now are going to take some remote testimony from Dr. Diana Barnard. If you can, please turn your microphone on and give your testimony.
Can you hear me okay?
Yes, please proceed.
Thank you. My name is Diana Barner, and I'm a hospice and palliative care specialist from Vermont, where I have more than 30 years of clinical experience, and more than half of that has been focused exclusively on caring for patients with serious illness. I do prescribe under Vermont's aid in dying law, and I also educate and support the practice nationally. In 2025, the way we die looks very different from how it did many years ago, when most of us died from sudden or short-lived illnesses with few treatment options that existed. Modern medicine has now made it possible for many of us to live much longer lives and with more advanced illness, which is a great success. But this success means more of us will live the final phase of our life with more disease burden, more symptoms, and more suffering, much like Andrew. We need new tools to assess this complex suffering and to treat it. Dying is such a deeply personal and unique experience, and some people will find deep meaning in the final weeks and days of life with symptoms that can be well managed. But others experience suffering that is difficult or even impossible to alleviate and feels meaningless. When people are first diagnosed with a terminal illness, they focus on treatments to cure or slow the disease and manage symptoms. It's only when the disease becomes much more advanced and treatment options are exhausted or become intolerably burdensome, then people must accept that they are dying and shift toward wanting a say in how they die. Having options to manage suffering is such a tremendous comfort. Of course, patients have a variety of beliefs and values. For some, they know now that medical aid in dying would never be an option, and that is okay. Others believe that medical aid in dying would definitely be one of many options, and that is okay. The truth is, most of us don't know what suffering we will experience at the end of our lives, and the key thing is about having options. The practice of medical aid in dying, as you have heard, is completely voluntary, both for clinicians and patients. And those who do not believe in the concept do not participate. There is no mandate. For those that want the option of medical aid in dying and who qualify, they must undergo a thorough evaluation with several safeguards that you've heard about, with two independent clinician evaluations to confirm that the patient qualifies, a mandatory waiting period, a written request, and the patient is reminded of their ability to pause or stop the process at any time. If medical aid in dying is utilized, the medications include a compounded powdered formula that's mixed in a small volume of liquid and self-administered by the patient, who makes that final ultimate choice on their own. Patients reliably become unconscious and go into a deep and peaceful sleep in very few minutes, and patients remain in a deep and peaceful sleep until they die. And most people die within a couple of hours. You will hear from people who are fearful about medical aid in dying and who sometimes discuss concerns that can be exaggerated or unfounded even. I really encourage you to do your own fact checking. And I speak for 27 years of national experience with clinical guidelines that show that the law are working very well and as intended and without abuse and coercion. In Vermont, where medical aid in dying has been legal now for 11 years, our most recent Vermont Department of Health report indicated that a total of 208 people have qualified for the practice, and the vast majority of those have been dealing with cancer. I want to close with the story of my father-in-law, Ken Mayers. We called him Pops. In December of 2024, Pops was diagnosed with esophageal cancer. He was a vibrant, active military veteran who loved to cook and eat. We called him a foodie. And when Pops was diagnosed, he wanted to live, and he sought treatment to help this happen. He even accepted a feeding tube for nutrition when he could no longer eat or drink anything by mouth. His goals were very modest: to get his mail, to walk his dog, to fill his bird feeders. But unfortunately, the illness made most of the decision, and time marched on quickly. Even these modest goals were not achievable. As Pops faced a rapid decline, he told us his quality of life had become unacceptable and that he was suffering, and he wanted to use medical aid in dying. After 88 remarkable years telling stories about his life and telling us just how ready he was to lay down his heavy load and rest, he went to his bedroom, laid down his exhausted body, and with his family by his side, took his aid in dying medication. He was asleep in less than a minute and died in less than 15 minutes. The majority of residents of your state of Illinois want the option of medical aid in dying, and I urge you to pass SB 9 this year. Thank you for the opportunity to share my experience, and I'm happy to take questions now or later.
Thank you for your testimony. Let's first hear from the opponents, and then we'll open it up for questioning. There are two witnesses here in the hearing room seeking to give testimony, Sebastian Niles from Access Living and Dr. Sharon Quick. If they could come to the witness table, we'd appreciate that. And then we will also hear testimony from a witness remotely. Oh, I'm sorry. First, we're going to go remotely. Okay. And is that to Dr. Brian Callister? Okay. Dr. Callister, can you please turn on your microphone and give your testimony?
Yes, can you hear me all right?
Yes, we can.
Okay, very good. I'm Dr. Brian Callister. I'm a professor of internal medicine in Nevada with 37 years of experience. I have been involved with end-of-life issues all of my career, and I'm testifying today because of two events that happened to me a few years back. I had two patients that came in to our hospital, one from Oregon and one from California. Oregon had had the law for 20 plus years, and California had passed it a year or two before. Both the patients were infected, but had treatable diseases underlying that, and both required treatment, standard treatments, not experimental, that could be provided outside of our area. I'm in Reno. One patient could get this treatment in Portland, and one patient could get this treatment in Sacramento, California. We arranged for transfer and had accepting physicians in both places, and I was requested in both of these situations to do a peer-to-peer review. And in both cases, the insurance medical director said to me on the phone, almost identical conversations from different states, we're not going to cover this procedure or the transfer, but, by the way, have you talked to them about medical aid in dying? Now, these patients weren't seeking palliative care or temporizing measures. These patients, the two of them, would have been curable between 50 and 70% of the time. Compassion and Choices likes to say that these two instances were made up, something like that. Well, I will reference for the record the article in the Washington Examiner by William McMorris titled "Vegas Doctor Vouches for Former Colleague's Account in Assisted Suicide." That was Washington Free Beacon, for the record, June 5th, 2017. That was my senior resident who was with me during these experiences. Not allowed to speak because he was a medical resident at the time, but once he finished his residency, he went public confirming the story. I did not have a dog in this hunt, as you might say, before these episodes occurred. That's when I got involved. I have nothing to gain by this. I'm not paid. I'm not reimbursed one penny for my testimony by anyone. I've never taken a penny. What this tells me is patients like mine that don't request assisted suicide can be denied treatment, because in these laws, it lists assisted suicide as a medical treatment option. Now, insurance companies will tell you, and they said in my two cases, there was no correlation between denying one treatment and approving another, because this is considered a treatment. That being said, what can you do if you want to live and your insurance company says no? So what I'd like to say to you is, when does one patient's right to die become somebody else's duty to die? Compassion and Choices, which was originally known as the Hemlock Society, was founded by Derek Humphrey, who wrote the book in 1998, Freedom to Die. And he wrote in that book, in the final analysis, economics, not the quest for broadened liberties or autonomy, will drive assisted suicide to the plateau of acceptable practice. And I'll tell you already today, I have heard some things that are simply untrue. We are very good, 37 years in my case, at giving you a diagnosis. We are very poor as physicians and telling you how much quality time you might have left. The medical literature is clear. A physician's average error in predicting life expectancy when you're first given a terminal diagnosis is off by an average of 70%. 70%. Now, with palliative care, hospital, medical treatments that are available, if tremendous pain, there are for that. And I must disagree with Dr. Barnard that it's impossible to get people to a place where their pain is controlled. There are things called palliative coma and otherwise, which she's well aware of, which can achieve that end. I will also tell you, as you hear more people talking about their horrible experiences with death, I need to point you to the Oregon data, almost 30 years. The percentage of patients asking for the medical aid in dying assisted suicide pills in Oregon that list pain as their primary concern or even a future concern for pain was 26%. That's it. And that included future concerns for pain. So what were the most common reasons for requesting the pills? Loss of autonomy, loss of enjoyment in usual activities, financial burden, and burden to family, which I am telling you are horrible social problems at the end of life. But last time I checked, they probably weren't great reasons for knocking yourself off. The other thing you need to realize about this is when you're terminal and we don't know how long you're going to last, once you get to the last weeks, days, hours, we're pretty good at figuring that out. But until then, who knows how much time you have? My own secretary was diagnosed with pancreatic cancer, not operable. She's still kicking around after 34 rounds of chemo, and she was diagnosed in 2016, 9 years ago. Is that unusual? Yeah, but it's not rare. The other thing you have to realize is these so-called safeguards are not safeguards at all. Physicians refer to like-minded physicians. In California, Oregon, and Washington, you have situations where the person who evaluates you for assisted suicide has a colleague to be the second doctor. That's what happens. You hear about the psychiatric screen. In 27 years of Oregon's experience, less than 4% of patients have been referred for a psychiatric exam. And guess how many have been denied the pills because of psychiatric problems? None. That's not a safeguard at all. I've actually heard the head of Compassionate Choices testifying in one state about these very safeguards you're hearing about, while simultaneously in another state that already had the law, at this time Washington, they were arguing in that legislature to get rid of the safeguards, claiming that it reduced access to care. I don't know why they call this care. And by the way, I call this assisted suicide. It's offensive to some of those proponents, but I consider the terms medical aid in dying and death with dignity offensive because it's candy coating what we are doing. We are not alleviating suffering. We are purposefully drawing up overdoses intended to kill a person. We can treat with better hospice, better palliative care, education, and funding, not by throwing the baby out with the bathwater. When you're first diagnosed with a terminal illness, obviously you're going to be devastated. I would be. I'd be depressed as heck. You have those pills in your drawer. What's to keep you on a dark and stormy night from taking those pills? And who knows how much longer of good quality time with your family you would have had. The other thing you have to remember is certifying, as I mentioned, our prognosis can be way, way off and extremely variable. I heard Senator Holmes say, these doctors certify you have 6 months or less to live. On regular hospice, 20% or more of patients nationwide outlive their diagnosis. In Oregon, only 40% of the people who receive the suicide pills actually take them in the year that they were prescribed. What happened to the other 60%? Certainly went a lot longer than 6 months. And what happened to all those deadly concoctions that are out roaming around in people's houses? Who could take them? Who could use them? Who could abuse them? Finally, I want to leave you with this thought. The suicide contagion. Compassionate choices will tell you, and we tell you the fact that suicide, general suicide, not counting this, increases in states where this is passed. They'll say, oh, that's not true because suicides increased all over the country. That is sadly true. But I'll tell you, in the time period when national suicide rates had sadly increased by 23%, the rate in Oregon, the general suicide rate in Oregon went up by 48%, and it skyrocketed in veterans because we're condoning taking life, and we're literally throwing the baby out with the bathwater. Before you are truly at the end and may have a lot of good quality time, you now have the option to take your life at any time. That, by definition, is suicide. I would also finally like to comment on what Senator Holmes said about the death certificate. What she told you is true, and I consider that Medicare fraud. We're not allowed to put assisted suicide on the death certificate in the states where this is legal. We're supposed to put whatever the underlying diagnosis is. And by the way, in Oregon, that underlying diagnosis has sometimes been things as simple as arthritis or diabetes. And the law says terminal with or without treatment. So if you're a diabetic and you stopped your insulin, you'd qualify. It's not hard to qualify for this. So when you look at this roundabout, putting on a death certificate, a legal form, pancreatic cancer, where it was really assisted suicide, that's not only Medicare fraud, but it's also totally ruining any chance we have at figuring out good treatments for pancreatic cancer with regard to how they work in the population. Because we're going to have this skewed population that took the suicide pills that look like they died much earlier than they might have. How are we going to know the true length of the terminal illness, the true prognosis for those patients when some are taking pills and it's to kill themselves and it's not even reflected on the death certificate? The bottom line is that assisted suicide does not expand your access or freedom to health care. It's the cheapest option, and it provides an incentive for insurers to deny treatment. The idea about two witnesses, and one can be a relative and one can't, what's to keep a freeloading grandson from telling granny she doesn't want to suffer with her arthritis anymore because he wants the equity in the house, and he and his living girlfriend are the two witnesses? Because once they get the pills, there's no witness required. 80% of assisted suicides have no healthcare person present at the time of death. This is a travesty. And to hear over and over, there's never been an example of abuse or problems in 20 years of Oregon data is simply untrue.
Doctor,
I urge you-
we have other witnesses seeking to give testimony, so if you could bring yours to a close, please.
Finish up right here. I would urge you to really think about the can of worms we're opening. And again, people who want to take such control of their lives to the ultimate moment because of the insurance issues especially, I will say again, when does your right to die become somebody else's duty to die? Thank you very much. It's been a pleasure talking with you today. I'll be around to answer any questions.
Okay, next we have either Dr. Sharon Quick or Sebastian Niles. Okay, go ahead. You filled out a witness slip, Bob? Okay, go ahead. Please identify yourself and go ahead with your testimony.
Good afternoon, members of the Senate Executive Committee. My name is Sebastian Niles, and I am the Healthcare and HCBS Policy Analyst at Access Living, a disability service and advocacy center led by and for people with disabilities in Chicago. Access Living has monitored and engaged on the national debate regarding end-of-life options since the 1980s. Disability organizations, including Centers for Independent Living across Illinois, American Association for People with Disabilities, the ARC of the United States, the National Council on Disability, and the National Council on Independent Living have maintained the stance that physician-assisted suicide provides an additional avenue for people with disabilities to experience harmful discrimination within healthcare. Here are some of our concerns on this matter. Number one, autonomy versus disability discrimination. The conversation around PAS must center the voices of disabled people, especially those in marginalized communities. While proponents argue for bodily autonomy, we must question whose autonomy is truly protected and whether this policy reinforces the devaluation of disabled lives. Number two, system inequities in healthcare impact end-of-life decisions. People with disabilities, particularly Black, brown, or poor disabled people, experience healthcare discrimination that limits access to proper treatment and care. There is documented evidence from other states where insurers deny coverage for expensive, life-extending treatments but approve PAS, subsequently steering people towards death as a cheaper option. Number three, racism, disability discrimination, poverty, and euthanasia policies. People with disabilities are concerned that legalizing PAS without structural changes will normalize death as a solution to disability rather than improving long-term care and accessibility, especially for racially marginalized people. True choice means ensuring all people have access to the support they need to live before making end-of-life decisions, which does not often happen for people with disabilities. Number four, disability rights versus the right to die. As Dr. Callister had mentioned, data from Oregon shows that pain or fear from it is not the primary reason that people requested lethal prescription. The Death with Dignity Act report stated that, as in previous years, the three most frequent end-of-life concerns were decreasing ability to participate in activities that made life enjoyable, loss of autonomy, and loss of dignity. This signals a need to expand home and community-based services so disabled people can receive care without institutionalization, as well as increasing mental health supports for those who are disabled and terminally ill. Number five, no adequate safeguards. Safeguard provisions are limited, and evidence collected by the National Council on Disabilities shows that such safeguards often do not protect people with disabilities. Doctor shopping allows patients to continue to seek additional physicians until they find one who will obtain a concurrence in medical opinion. Kay Cheney was an 85-year-old with early dementia symptoms. Her physician had declined a request for lethal prescription, which led her managed care provider to find a second physician who ordered a psychiatric evaluation. Cheney failed this evaluation, angering her family. Another evaluation was conducted, and Cheney was deemed competent, while the report noted that her choices may be influenced by her family's wishes, and her daughter may be somewhat coercive. Cheney soon died by PAS. Number six, healthcare within the Illinois Department of Corrections. For people incarcerated within IDOC, the state struggles to provide adequate medical care for those who are elderly, disabled, or terminally ill. As described by an ACLU of Illinois attorney, prescriptions go unrenewed, cancers go undiagnosed, and in the worst cases, as everyone here knows, people die painful deaths because of a lack of care. William Dean was incarcerated in Taylorville Correctional Center when he complained of blood clots in his urine. Dean waited 4 months for a diagnosis of kidney cancer and another 3 months for surgery. A jury later found that Wexford Health Solutions deliberately delayed Dean's medical tests and treatment. Few individuals have been released by the Coleman Act, and with no available hospice care, incarcerated individuals are left to die in their cells. Legalizing PAS without addressing the severe health inequities within IDOC will lead to de facto death penalty sentences. Number seven, the ending of the Health Benefits for Immigrant Adults program. The future of HBIA, the funded Medicaid program for immigrants between ages of 42 and 64, is unknown as funding was not included in this year's budget. The program provides key health care coverage to 18,000 immigrant adults across Illinois, and to end the program would leave thousands without care, especially those with treatments necessary to survive. Those undergoing dialysis or diabetes must now make the decision to pay for out-of-pocket treatments and medicine, or ensure that they have basic needs. Medicine rationing can lead to terminal progression of otherwise livable conditions, and many HBIA enrollees will have to choose between slowly dying from lack of treatment or lethal medication if PAS is legalized. Access Living opposes SB 9 not because we oppose specific portions of the bill, but because bringing PAS to Illinois in any form will harm people with disabilities. However, it is also important to note that SB 9 itself has significant issues which showcases a lack of readiness to become Illinois law. Psychological evaluations are used to determine capacity at the discretion of a physician. There is no mandatory counseling or mental health screening for all patients requesting lethal medication. Depression and suicidal thoughts, both very prevalent in nursing homes and hospice care settings, can be a driving force for usage of PAS without impacting this capacity. Section 75, subsection A charges the Illinois Department of Public Health with creating and posting checklist and follow-up forms for physicians. Even if those forms are unavailable at the start of this act, the effective date of this act is not suspended. Lethal medication could be prescribed without these forms, which threatens the integrity of the year 1 reporting data available. Section 75, subsections B and C outline the required forms. However, subsection D was amended to remove the following. The department shall collect and annually review the forms filed pursuant to section to ensure compliance. If a physician is required to report information to the department under this act, provides an inadequate or incomplete report, the department shall contact the physician to request an adequate or complete report. Without verification of reporting compliance, there is no way to understand and fully know whether the annual statistical report for this bill contains accurate and complete information. Section 200 also amends Section 7.5 of the Freedom of Information Act and wrongfully refers to Section 70, which covers immunities, instead of Section 75, which covers reporting. We're not even getting into the gist of Section 80, subsection C, which covers insurance and the possible loopholes that are available there for insurance companies, as Dr. Callister had mentioned before, and then as well as that there's no reporting practices or mechanisms available for coercive practices. I would like to also touch briefly on the impact research study that was brought up earlier. We do not know and fully understand the methodology of this study because it is not available. We do not know which questions were asked to survey respondents and how they were worded. We also do not fully understand what misconceptions there are about this bill and how it works. There's also the potential for accessibility issues with the survey itself. I have a disability, but mine is invisible. Someone with a visible disability, say for instance spina bifida, which impacts your ability to walk, faces different challenges in healthcare settings than I would, as my disability does not come off as abrasive. Many of Access Living's consumers are people of color and people with disabilities that often face what we call double discrimination, is that you are impacted by not only discrimination and bias that occurs because of the color of your skin, but also the discrimination that you face as a person with a disability. In conclusion, supporters of PAS claim the passing of this legislation gives individuals a choice. However, our healthcare system can often provide an illusion of choice. An insurance provider covering inexpensive PAS medication instead of hospice care is not a choice. A physician offering PAS because they believe people with disabilities have a lower quality of life is not a choice. And being incarcerated with a terminal illness and choosing between a slim possibility of a release, dying in your cell, or PAS is not a choice. PAS as an option has significant ramifications for the health and safety of all Illinoisans with disabilities. Thank you for your time.
Thank you. Mr. Gilligan?
Thank you, Senator Cunningham. Bob Gilligan, with the Executive Director of the Catholic Conference of Illinois. I'm here today to oppose Senate Bill 9 on behalf of the Catholic Conference. Before I start, I'd like to say, Senator Holmes, I know you and I are on a different side of this issue, but I too went through something very similar that you did recently with a relative, and I'm sure many people in this room have gone through the same thing. We recognize it's a very emotional, difficult issue, but we feel that we oppose assisted suicide because this bill violates some basic tenets of humanity. That is, every person is precious. People are more important than their interests, and the measure of every institution is whether it threatens or enhances the life and dignity of the human person. Permitting physicians to assist patients with suicide strikes at the truth that we mutually recognize each other's equal, independent worth, the value we all simply have because we're human. Proponents will argue that they merely want the that they merely want the autonomy to end their own life. However, I submit to you that this is not just a personal choice alone. Rather, it creates negative societal consequences and causes real societal harm. Assisted suicide is not a private act. Friends, relatives, healthcare staff, and society are also largely impacted by the wider ramifications of this process. Assisted suicide is a violation of the common good, and it should be opposed. Today, we look to the negative consequences in other states where assisted suicide is legal. As we see it, there are at least 3 societal harms that will arise if this bill becomes law. The first harm is the potential for coercion and abuse. The second harm points to the increase in suicide that will occur. And then finally, the third harm is what Dr. Callister pointed out, that the quality of care in Illinois will deteriorate if insurance companies can offer these pills as a cheaper alternative than treatment. As the doctor said, it could become cheaper to kill you than to cure you. The first harm evolves from the fact that state law cannot protect all people from being coerced or intimidated into taking these lethal pills. There are documented cases of exploitation and coercion. Time does not allow me to go through those cases, but I'll refer you to a website. The Disability Rights Education and Defense Fund lists a number of these examples of coercion and exploitation. In this bill, there is no requirement for anyone to be present when the patient self-administers the drug and dies alone. Once the doctor approves the pills, he or she is out of the picture. Because no medical professional is required to be present, what happens when there are medical complications? There have been medical complications in other states, and once again, we can't go into all of them, but you can read them for yourself if you go to the Patients' Rights Action Fund website for some of these examples. Because there is no requirement for anyone to witness the death, how do we know it was voluntary? There's no meaningful protection to prevent an abuser or self-interested person from administering drugs to a sick, elderly, or disabled person against his or her wishes. Because the patient can hold on to the prescription for months, who verifies that the patient can make the final consent? What if the patient changes their mind and a family member coerces that person to take the pills? Not to mention, there's no requirement for safe storage for these pills. There's no 911 type of number in this legislation. There's no ombudsman. There's no protections that are contemplated in this legislation. In addition, the committee should be aware, and I think Dr. Callister mentioned this, that the bill allows one of the witnesses to be entitled to a portion of the person's estate. How can a person who stands to benefit financially from the person's death serve as the first witness? Once again, this leaves people vulnerable and at the risk of exploitation. The state cannot prevent coercion, it cannot prevent a misdiagnosis of a patient, and the state cannot prevent exploitation. The second harm is that more people will commit suicide. In a peer-reviewed study released in 2020 by David Patton, he found there is strong evidence that legalization of assisted suicide is associated with an increase in total suicides, especially for females and older people. As of now, it is the policy of the state of Illinois to bolster mental health services and try to curb the number of suicides. This legislation will work against everything you are trying to do. Sadly, 49,000 people committed suicide in 2023. That is someone's family member every 11 seconds. In addition, suicide risk increases by 2.58 times in families with a history of a completed suicide. I ask that you take into consideration not only the person who wishes to die by assisted suicide, but also consider how this impacts an innocent family member today. There are people out there today that are not doing well, and if this legislation becomes law, the state is giving them a green light to end their life. Legalize assisted suicide normalizes suicide for all. Thirdly, as you heard in Dr. Callister's testimony, with the availability of assisted suicide, the quality of care in Illinois will foreseeably deteriorate. I want to talk about, related to that concern though, is about the healthcare disparities in the state. There is not an even playing field when it comes to healthcare. The poor and the marginalized do not only have the same healthcare coverage as most of us in this room, but they also do not get the same level of care. If a disadvantaged person doesn't get treatment, their condition worsens, which could lead to a terminal diagnosis, and then assisted suicide could be offered rather than treatment. Please note that this situation could be getting worse. As you know, we face a healthcare crisis, with Medicaid cuts at the federal level threatening coverage for hundreds of thousands. The ending of the health benefits for the immigrant adults also places over 18,000 undocumented immigrants with no access to health care on July 1st. The proponents claim assisted suicide is a choice, but it's a choice for a few and not ruins health care for all. Finally, if this passes, the limited safeguards in this bill will soon become barriers to others who want to end their lives. No state which has legalized assisted suicide has tightened eligibility requirements after initial passage. Conversely, there are states that once restricted assisted suicide to their own residents now allow anyone to come to their state to end their life. There are states that are trying to eliminate the terminal diagnosis safeguard. There are states that are trying to expand assisted suicide to dementia patients. And there are states that do not like the requirement that the pills be swallowed orally and would like to have this done intravenously. There are countries where mental illness is now a reason to be offered assisted suicide prescription cocktail instead of treatment. In closing, the harm of legalizing assisted suicide far outweighs any purported benefit. The advances in palliative care and hospice care are the real compassionate answers to the end-of-life issues. The better path forward for the state of Illinois is to both expand palliative care and hospice care as they focus on symptom relief, quality of life, and family involvement. Care that is holistic, collaborative, and delivered by a team of specially trained providers. Every person deserves this. Thank you for taking the time to listen to my comments.
Thank you. Senator Holmes, do you wish to add anything before we open this up to questions?
Yes, and I'll be brief, because I think it's more important we make sure that members have the ability to ask some questions. But I do want to say, and especially because I am talking to members who understand this argument all too well, and some of you know the way I feel about the, quote, slippery slope, which drives me nuts, because I think we all in our work understand that there is no such thing as a slippery slope. Whatever other countries or other states or anyone is doing, or whatever you imagine may be done because of this, could not alter this bill without coming before this body. So we would be the ones that would make the changes. So the slippery slope is really not that slippery. The other thing I want to mention in reading is no person will be considered a qualified patient under this act solely because of advanced age, disability, or mental health condition, including depression. A diagnosis of a major depressive disorder as defined in the current edition of the Diagnostic and Statistical Manual of Mental Disorders alone does not qualify as a terminal illness. And I definitely at some point would like to give Compassion and Choices an opportunity to defend them from the accusations of one of the previous speakers. I do want to say, though, that it's not like people are all of a sudden, if you choose not to use medical aid and dying, you're jumping out of bed and running around and living your life. 88% of the people who end up choosing this option are already in hospice. They have already understood that there is no other life-saving measures that can be taken. They are dying. People wait usually to what looks like, and the doctor said is very good at diagnosing when you're in your last couple weeks of life, which is when people choose to do this. I also want to say this bill was introduced a year ago, February, when I introduced 3499, and had many conversations with Access Living. Literally sat there and said, please tell me What safeguards? What can we put in this bill? What would you like to see in this bill that would make you more comfortable? Never in the numerous Zooms, calls, conversations in person did we get any information. All of a sudden now, there's a whole bunch of ideas. I'm so sorry we didn't get those before. That would have been nice. But at this point, let's open it up to questions from the members.
Senator Tracy.
Thank you. Senator Holmes, you're to be commended for the amount of work you've put in on this bill, and I understand your passion. But I did have a question for Dr. McAllister, if he's still with us.
Yes, I'm right here.
Okay, thank you. Can you elaborate in the examples you gave of patients who were recommended for the prescription and called terminal? What kind of conditions were they diagnosed as terminal for?
In Oregon, there, in which we have the most data for. And one of the reasons for that is when Oregon, which was the first state to pass this law, had much more rigorous data collecting than subsequent states. So it's much easier to mine that data and actually find out what exactly people are going to request the pills for. There have been cases of there have been cases of arthritis. There have been cases of diabetes without any elaboration. Of course, emphysema, heart failure are the ones you would expect, and all kinds of cancers. But you do see multiple patients every year with diagnoses, and they put out a yearly data update. They put out their 2024 one just a few weeks back that show the different diagnoses. And that's something I think the committee would appreciate, because you can look at how many are other, arthritis, diabetes, chronic pain, things like that.
In your state, is there any way that there was protection for patients when there was insurance denial?
In my state, it's illegal. We've been able to defeat this bill. Our state legislature in Nevada meets every other year, and we've been able to defeat this every other year since 2016.
Well, actually, my question, I think I didn't state it correctly. What I'm wondering about is, for those patients that were denied insurance treatment, insurance payments for treatment that might have actually allowed them to live longer, not be terminated, or not be diagnosed as terminal, what would protect them? How can we protect them against these insurance denials rather than just saying that they're terminal?
Well, a key tenet of these bills, and I think it's important to note because I think it's the only way that you could administer these medications, is the fact that it's considered a, quote, medical treatment, unquote. If it's a medical treatment, the insurance companies are free to approve or deny it, just like any other medical treatment. With that being said, again, the insurance companies I dealt with claimed no coercion between the treatment that was offered and the treatment that was denied. There's a case in Southern California, Stephanie Packer. I know her personally. She has a ultimately terminal disease, but has done well for years and years. She's a single mom. I think she's in her 40s now. She's done great. In the same sequence, she got a letter from her insurer saying they were no longer going to cover the extremely expensive, it was 4 figures a month, extremely expensive medication that was keeping her alive. In a separate letter that arrived within days of each other, she was informed that she could apply to medical aid in dying with a $1.20 copay. And fortunately, Stephanie's still alive.
You're probably the best one to tell us what is actually in the prescription that would terminate the life.
Yeah, the first thing that they used for years and years was Seconal, and that's a barbiturate. And they would take 100 capsules, try to swallow 100 capsules. That's just crazy. Lots of people would vomit, and this went on for years and years. And people died anywhere from a short time, 15 minutes, and I heard that from my colleague in Vermont, 15 minutes, to as long in Washington State, the longest is 107 hours. That's not
Excuse me, can I step in for just a second here? We have a lot of talk about things in other states, and I appreciate how that might provide some context. But I think it's important we debate within the guardrails of this bill, what's in this bill.
I appreciate
you.
that, but I believe he's the only physician, and that's why I was wanting to know what.
No, there's other physicians that are.
Well,
I thought she was a nurse
Who
practitioner.
actually does this?
Okay, but I thought she was a nurse practitioner.
No.
And not to say that I love my
No.
nurse
She's
practitioner.
a
Okay,
physician,
okay.
and she actually does.
Okay, well then perhaps she can tell me what's in the drug talk
she
cocktail.
would know because she's
Okay,
is
fine.
the one
Yes. Her name
prescribing.
is Dr.
the current one, I'll say, is digoxin, diazepam, propranolol, and what happens is the patient takes it in a slurry. You heard one person say that they put it in a sorbet and swallow it that way. And again, the length of time for death has been minutes to many, many hours in some cases.
Okay, well, our Vermont physician, if you will, I'm sorry I overlooked that credential. Could you please tell us what you use as the drug cocktail, if that's appropriate? I just want to know what's in it. What
No,
would be in our
that's
drug
fine.
cocktails?
Doctor?
So first of all, I would say it's important to understand that in the field of medicine, things do evolve and change with experience. So I'm happy to share with you what we believe to be the best practice and has been reliable currently. And also just to say that over time, this may well change. The current mixture is a compounded mixture of medications that are all FDA approved, but of course are used in much higher doses than what would normally be used to support a patient who's living, because the medications are designed to help the patient go into a deep, peaceful coma and to stop cardiorespiratory function. And so those medications include digoxin, 100 milligrams, diazepam, 1,000 milligrams, morphine, 15,000 milligrams, amitriptyline, 8,000 milligrams, and phenobarbital, 5,000 milligrams.
Thank you, that's what I wanted to know. And then, have you seen any shortage of opiates in your practice?
There have been a couple of times in the past couple of years, including when the hurricane hit Puerto Rico, where a lot of opioids are produced, where certain formulas of certain opioid medications were hard to locate. And we are fortunate there are different classes of opioid medications or different kinds, and we have been able to substitute what we call equal analgesic, or one type of opioid for another.
Okay, thank you. Senator Holmes, how much medication is allowed to be prescribed under your bill? The dosage? Like, is it 3 pills?
Well, no, because we don't, again, because as the doctor said, the medication is going to sometimes change formulas, simply like my MS, as they come out with better treatments, I try different medications.
So your
and
bill,
in differing amounts. So it does
it
no.
does not
No.
specify. Is the quantity specified?
No.
So
Because again, it would depend on the drugs.
Okay.
Because there's no way, you don't want to write the drug in here any more than, because you want medical advances to.
But you also don't want too much of it, I suppose. I mean, is it just for one dose?
Yes, because obviously it's meant to
And will it
end
have
your
an
life, so you don't
will it
take
have
more
an
than one
expiration
dose.
date on it? You know, I think somebody said they put it in the refrigerator for a long time. And I just wonder, does it say it expires or?
Well, all drugs, and again, we can confirm with the doctors, but I'm sure all drugs have to have an expiration date on them. I mean, your prescriptions do at home.
But there is.
And most people understand they're not expected to live more than 6 months. I understand there's some outliers that do, but again, a lot of people don't necessarily get the drug right away. They're sort of waiting and hoping that they're not going to need it.
Sure.
Could I add something?
Yes. I mean, it's not my. Yes.
I would say, first of all, yes, as I indicated, the current formula that we are using and have been using since 2021 is a compounded formula, and any compounded medication that's put together must have an expiration date of 6 months. That is just the law. I will say that it's important to understand that this whole thing about medical aid in dying is a process and something that goes through carefully step after step. And for example, in Vermont, our practice is often to qualify a patient, meaning we go through all of the steps and then we pause and we actually wait to see what happens. And we encourage people to regularly check in with us to see how they're doing. And our practice is to not prescribe the medication and have it delivered until the time is close and the patient is sure that they want to move forward, in order to make sure the medications are still in good shape, and to keep medications from being circulating when they don't need to. And most importantly, to be sure that we are clinically checking in with the patient continuously, because even patients who want the option of medical aid in dying, in my extensive experience, very much want to live. And they keep on living as long as they can.
And I think that's good input. Senator Holmes, does your bill contain that type of checkup with a physician, requiring them to keep in touch with their physician so that they can see how the patient's doing? Has their condition improved? And
There's no requirement that once they get the prescription, they have to do a check-in, and that's similar to the language that exists in other states. So we didn't add that additional language. I think Dr. Barnard talked about how those things happen depending on the physician. So we didn't include that there. I do want to, you did ask about the insurance question, and I hope I can answer it for you. So we have a provision in the bill, Section 85. It talks about insurance policies. Section C essentially says that an insurance plan can't deny or alter benefits because of the existence of medical aid in dying, so for terminal patients. So because it exists, you can't then say we will cover this but not that. That is against the law. That would be against the law. We also added a new provision with the amendment that makes it clear that the Department of Insurance would they would enforce the law. So I guess to the question of accountability for insurance providers who do not follow the law, there's a mechanism in place to hold those folks
okay, and I
accountable.
also was wondering how the insurance in this bill is addressed that sets it aside from if you commit suicide, you're not covered, but under this bill, you are covered. How are we covering that, and what's the language?
So the approach there is because the underlying condition is your terminal diagnosis, so because it only applies to people who are terminal, then for the purposes of this act, using medical aid in dying, you're a qualified person, your underlying illness would be the thing that's on your death certificate. So and that is different from suicide. So that's the approach that's taken.
Okay,
there.
thank you. So, and that brings me to another question I had about the death certificate. Doesn't it seem that it would be more informative to list on the death certificate an example of pancreatic cancer through and with medically assisted aid or whatever because then you have your data for the illness, the underlying illness that prompted the physician aid. But likewise, we're going to have statistical data as to how many people are using it, because I think both are important. We want the medical family background, but likewise, it's important to know how often it's being used, because otherwise we have no data on that at all.
We have reporting requirements on the actual usage of medical aid in dying.
With public health?
That are in the bill that will tell you, where are the reports? So if you look at the bill, you'll see that there are reporting requirements in there of what needs to be done. And it is the number of prescriptions for medication written pursuant to this act, the number of physicians who wrote prescriptions for medication pursuant to this act, the number of qualified patients who died following self-administration of medication prescribed and dispensed pursuant to this act, and the number of people who died due to using an aid in dying drug, with demographic percentages organized by the following characteristics. So, I mean, there's a lot of information that actually
Who's
is
going to
being
report
compiled
that?
and reporting.
Does that get reported to?
Well,
So the physician would report it to the IDPH. And every time they do a prescription, they would have to report it to IDPH.
And then will IDPH do an annual report?
So it would be available on their website in a de-identified manner. But yes, there would be a report that's available so folks would have a sense of who.
And one other factor is, for purposes of scientific research, isn't it important to know that that person died of pancreatic cancer, but they were medically assisted? So we need to know how long that patient might have lived. I mean, it's important to know that they terminated rather than the length of the illness. I do think that's important.
your death certificate doesn't say how long you had the disease.
Well, I mean, the fact that you're being terminated definitely has some scientific research or otherwise. I mean, it does have significance, because that pancreatic death occurred earlier than it might have. I mean, so I understand your point, but yet they're being assisted to die at a certain date.
But you wouldn't have any idea, was that 10 days before it would have? Was it 1 day before? I mean, I don't know how you calculate that. I mean, and again, death certificates don't go into that much detail.
That's true. I get that, but I likewise think that death was
Again, you're going to get more information off the reports from the
true,
doctors
and I'm
are
glad
having
to hear that.
to do.
Next, about the mental capacity.
Can I just, to your point about the death certificate having the, that you use medical aid in dying, I guess I would say that for, if somebody decides to not use life-sustaining treatment, so they decide to be off a ventilator, you don't necessarily put that information in a death certificate. So I think it would be treating this a bit different. And I guess to Senator Holmes's point, the information about whether or not aid in dying was used would be covered in some other way.
Next, as I said, I was wanting to discuss medical capacity, and I see on page 6, line 14, it does define medical capacity in that, in the opinion of the attending or the consulting, not both, but one or the other, if in the opinion of the licensed mental health care professional is required that, going on, the patient requesting medication pursuant to this act has the ability to make and communicate an informed decision. Medical capacity for testamentary intent is that you know who your heirs are and the extent of your property. I'm just trying to figure out exactly, this just means that the mental capacity is that it's pretty loose, actually. It just means that you're requesting the medication and you can communicate that you're requesting the medication. To me, that might overlook a lot of mental layers of depression or other things that would, I mean, to me, it just says, yeah, I'm requesting the medication and I know I am. To me, that's, I mean, is that how you interpret it? To me, that's a little loose.
So if you go to page 18, section 45, there's a process for determining whether or not somebody has mental capacity. This language was also language we worked on in consultation with ISMS in terms of the standards that physicians use to determine whether or not somebody has the capacity to consent for care generally. So,
Okay, so tell me what, I don't have page
Oh,
45,
so,
so tell me what it reads, please.
so-
I'm sorry.
yeah, so there are four different sections. So if either the attending physician or the consulting physician has doubts whether the individual has mental capacity, and if either one is unable to confirm that the individual is capable of making an informed decision, the attending or consulting physician shall refer the patient to a licensed mental health professional for a determination regarding mental capacity. The licensed mental health professional shall additionally determine whether the patient is suffering from a psychiatric or psychological disorder causing impaired judgment. The licensed mental health professional who evaluates the patient under this section shall submit to the requesting, attending, or consulting physician a written determination of whether the patient has mental capacity. If the licensed
Okay, yeah, but it doesn't define mental capacity. There's no other definition for mental capacity that you're reading and what I'm reading, unless there's somewhere else. It just says, yes, I'm requesting it, and I know I'm requesting it.
So, I guess going back, to understand what you're saying, that the definition that we have on page 6 that says mental capacity means that in the opinion of the attending physician or the consulting physician, or in the opinion of a licensed mental health care professional, the patient requesting medication pursuant to the act has the ability to make and communicate an informed decision.
Right, you say, I'm requesting it, and I know I am. That's mental capacity under this bill.
I think, and Erin could correct me, in some of the conversations we had about it, there was the idea that physicians determine whether or not somebody has mental capacity all the time.
But I think,
So the idea of putting it into a statute, I guess I'm curious in terms of what specific things are you looking for?
like I say, testamentary capacity is defined that you know what you own and you know who your heirs are. To me, it would be very helpful if we had a mental health provider as part of this, because we're dealing with people who are in dire situations and may likely suffer some form of depression because of their diagnoses.
But and the law does require that if a doctor can't determine it, they go to a licensed professional, and I think that's what I was reading earlier, where they would determine whether the patient is suffering from a psychiatric or psychological disorder causing impaired judgment. So that's in there.
And I think Dr. McAllister testified that he has seen no denials based on any mental health.
I wasn't under the impression that Dr. McAllister does this work. And I could ask Dr. Barnard to share her perspective since she has some experience in it.
Sure. Doctor from Vermont, if you could tell us how you define mental capacity and how you see it, and when would you bring in the mental health professional?
Thank you for that question. Yes, so evaluating a patient's ability to be capable and competent to make a medical decision is part of my routine practice every day before I write a prescription or do a procedure. Physicians and other health professionals are continually evaluating, does the patient understand what they are asking for? Do they understand the consequences of the choices they are making? Do they understand the alternatives? And can they, we sometimes call it teach back. When I have given them information, can they teach it back to me or speak it back to me in a way that I know they have heard what I've been sharing and understand? In the vast majority of cases, if there is concern about whether or not a patient has such capacity, and this is actually, not uncommon when you're living with a neurodegenerative disease or a cancer that could affect that, what you need to understand is that in most cases, the process simply stops and the patient cannot move forward. If I don't believe the patient is capable or has capacity, I do not move the process forward, and there never will be a report because they don't get medications. If my consultant likewise feels, they too can stop the process. It's only because we are trying to be so respectful of patients' rights and access to information and medical care that is legal, that the law allows for, if there's some doubt, if the patient seems, if I'm not sure the patient has capacity, then just like in any other case, when I'm working with a patient and I'm trying to figure out if they have the capacity to consent to a medical treatment, that is when I go to my expert from a psychological evaluation to give me an additional layer of expertise to help me feel secure that the patient has that capacity or does not.
In your
Did I
practice,
answer the
do you
question?
know how many times you've prescribed the medically assisted aid?
Yes, dozens.
But no number,
I-
actually. Dozens. How many times have you referred to the mental health professional?
I have never made a formal referral to a mental health professional, and I have several times told patients I am unable to prescribe because they do not qualify.
They didn't have the
because
mental
they do
capacity.
not have
But how do you,
capacity.
so you've never felt like one of these terminally diagnosed patients could be suffering from depression? Is that what you're saying? Or have you, how do you discern if somebody may be in a very depressed condition because of their diagnoses?
It's a common part, particularly of my palliative care practice, to be able to assess patients for depression that could impair their clinical judgment. The depression is a very important part of our care, and it's uniquely evaluated because so many people living with advanced terminal illness have a lot of the physical symptoms of depression, like fatigue and other issues. So it is part of my regular clinical work and part of my evaluation. And if I am seeing a patient who I believe qualifies and has capacity, and if they have a mental health provider, I have had several conversations with the entire team that's treating the patient, including their mental health providers. But that's different than a formal evaluation for capacity, because in the vast majority of cases, especially since the process is voluntary, and I want to follow the law because I would never want to be held accountable for doing anything that is not in accordance with the law, most often the process simply stops and I say no, and there's no need for a referral. There's good experience out of California in the Kaiser system, and we can get you that information more specifically, but they set up an internal system where they had a mandatory psychological evaluation because they were really concerned and wanted to be sure they were being respectful of patients and evaluating them thoroughly. And after they had that in place for a period of time, they actually removed it because it was so often not needed. So that's an experience that we can.
Okay, and I believe this is my last question. I was just wondering, in your practice, have you seen people with physical disabilities or developmental disabilities or mental disabilities seek your treatment and be given the medically assisted aid?
No, and that doesn't surprise me because, well, I maybe should clarify your question. The presence of a physical disability or depression alone would never qualify anybody. I have written prescriptions for patients, for example,
Well,
living with
but
less.
okay, but I was just thinking though, if they had one of the qualifying conditions and they were physically, mentally, or developmentally disabled, have you
Not
seen?
developmentally disabled, no. The only issue that came to mind, and I'm sorry because I didn't want to misspeak, was if a patient's living with ALS and a neurodegenerative diseases, often those patients have developed physical changes that leave them with a disability related to their terminal illness.
Okay, thank you. That concludes it. Thank you. Thank
Senator
you for your
Resin?
questions.
Thank you. I I have a couple of questions, and the first couple are just short questions because I'm sure you'd like to move on. So first of all, thank you. This has been informative for me to listen to certainly both sides. Regarding the data collected, it's collected, who has access to see the data?
Oh, so it's collected by IDPH, and there is a version of it that would be available. So,
So what's the version available?
So I could have somebody from Compassion and Choices talk about what that's looked like in other states in terms of what's been implemented.
So
if
is
that's-
all of the information available for the public to see and analyze is my question.
No. So the language that we have talks about you would be able to get information about, generally speaking, people's age at death, education level, race, gender, the type of insurance, underlying conditions, and that's how we've been able to gauge how medical aid in dying has worked in other states. So if it's okay with you, I can ask Chloe from Compassion and Choices to share.
Sure, that's fine. Also, illnesses, again, I'm not quite sure why on the death certificate you're not listing the illness and then also medical aid in dying, because what my colleague just said is it will skew the data for somebody who has a terminal illness, such as, cancer, some kind of cancer, a new medicine or a new treatment comes out where potentially their life could be extended from taking that medicine. But now if they decide to go this pathway, it will be skewed because they will not live as long as they normally may have.
So that's a great question. I think one really good example of that is
Sorry,
that-
can you identify yourself first?
Hi,
Thank
my
you.
name is Chloe King. I'm from Compassion and Choices Action Network.
Thank you. Go ahead.
So our storyteller, Deb Robertson, is actually in experimental treatment right now for her terminal cancer. She wants to live as long as possible, and she wouldn't request this medication until she had reached the point where those treatments weren't working anymore. Yes, sometimes people die
Prematurely.
and then treatments come out that could have elongated their life later on. However, that's the reality of every single terminally ill person for all of time.
Okay, thank you. So there are safeguards built into this, and one of the previous persons who testified said that in Washington, I believe, that the safeguards are being removed after this bill was passed. My question to you is, the safeguards that are in this bill, should it pass, do you have any intention in the future to remove the safeguards built into this bill?
Absolutely not.
Okay. And in terms of prognosis or illnesses that are included in here, is there any intention to expand upon illnesses that are currently covered in this bill in the future? For instance, like adding arthritis to the list.
Of course not. I mean,
I know it's not for you, but
I mean, arthritis is certainly not something that is, I have never known of a case where you have terminal arthritis.
It just came up in the
Right, I mean, but it
on
just,
the pan or in
it
discussion. I just
doesn't
want to
make
make sure.
sense.
I know your intention, and I trust your intention. But as you know, we're not down here forever. So I just want to make sure that the intent of this bill is what it is, and there's that you won't be expanding it in a year or two or whatever in terms of those
No,
areas.
and that's why I think we spent so much time trying to make sure there were all these guardrails and protections.
And I
So
appreciate that.
there's no desire to weaken them. To be honest, there
Oh, I
are
know you've been
people that have come to us that are like, well, why can't I do an advance directive in case I don't have the mental capacity when it comes? And it's
do
like,
it.
that is not even something we are touching. 'Cause
Sure, and
that's-
I appreciate that. I guess looking at this and listening to the conversation that we've had, my biggest concern in this whole process is the ability, because we know where healthcare is going. I mean, there has been an increase in accessibility to healthcare. There's, because of less money in the budget for a multitude of reasons, creates pressure on the healthcare system to deny certain whatever it is in healthcare. We deal with it on the policy side all of the time, irrespective of this conversation today. There was a poll or some statistics that were talked about from one of the panelists, I believe Dr. McAllister, about when people were asked at the end of life, why did you make this decision? And something that was very glaring to me was that, and it was a high percentage, made this decision because they felt they were a burden on their family or that this was a financial burden. So when you take those two issues and you put them together, are we creating something by passing this bill? Are we creating an opportunity for people who, no question, I mean, have to make very difficult decisions, right, in their life because of this? And it's not so much, they're making the decision because of what's being forced on them from the lack of access to health care insurance side. Is that going to move them to look at the medical aid in dying as an option, as opposed to the pain and the suffering that was, discussed earlier? That's just my concern. I don't know if there's an answer. I
No,
think
but
it's a
I
legit
think-
concern, though.
I think that when you look at the fact that 88% of the people that are choosing this option are in hospice care.
Yeah.
I mean, so they're already under some sort of medical care like you would need to be at that point because, again, like I said, it strikes me somehow as odd. It's like, well, if we're doing this and shortening somebody's life, they'd be living their life. I'm sorry. I watched both my parents at the end of their life. They weren't living a life. They were laying in bed, not even able to get out of bed, even to make a trip to the restroom. I mean, when people are at this stage of their life, when it is so close to the end and they are dying, they aren't living a life.
Yeah. Well, and I appreciate that. Again, that's my concern with this, but what I do appreciate, first of all, thank you for the testimony, very compelling. Thank you for sharing your story with us and on both sides as well. I'm just incredibly concerned about the role of healthcare and the inaccessibility that we have now to access the system that might be, I don't even want to use the word motivating factor, but a factor that may be considered, especially hearing about some people look at making this decision because they feel that it's a financial burden, which is terrible. I mean, it's a very difficult topic to discuss, but those are just my concerns, and I appreciate all of your work on this, Senator Holmes. I really
And
do.
oddly, we've had criticism the other way saying that the ability to choose the option of medical aid in dying does not allow people who aren't as wealthy to participate in it.
Yeah.
So it's that argument's coming both sides, which you can't have it really both ways. It's one side or the other.
Yeah.
But
No, I agree, but it's important to have the discussion, so I appreciate that. Thank you.
And Senator Reza, I just want to appreciate that thoughtful response, because I think in the years of doing this work, even without this law in place, I think people who are at their end of their life are facing really difficult choices. Do I ask to be on a ventilator or not? Do I continue with treatment? Do I not continue with treatment? So I think those are questions that are already happening. I think part of why we have some of the safeguards that we do as it relates to insurance is to make sure that this doesn't become the thing that you fear. And I think that's also why it's really important for people to have this choice, that they have the opportunity to talk to a mental health provider if needed. They're not making these decisions alone. They're not using other ways to end their life. So, but I appreciate the question.
No, thank you. And I'll just close with this. I mean, I think it was Dr. Callister who testified that he did have patients in California and Oregon who were denied treatment coverage by insurance companies in their homes and instead were offered this option. Again, I hear that. It's concerning to me as you're trying to figure out what the pathway forward in this is. So thank you very much.
Thank you. And so in the process of talking to their attending physician in the first conversation and at the very last conversation when they get the medication, at every step that provider is required to talk to them about all of their options. And I think that's why we're very intentional. So it's not just talking about medical aid in dying. We want people to know about hospice care and palliative care and all of these other things as well. So thank you so much.
Senator Murphy.
Thank you, Mr. Chairman. Thank you for bringing this forth. I know how difficult these end-of-life decisions are. But what I'm struggling with is some of the opposition. And we have legalized hospice care since 1983. For 42 years, we've had hospice. And hospice doesn't require a mental health referral. Hospice doesn't even require you to be of sound mind in order to enter into hospice. You don't have a medical professional at hospice at end of life. 50% of hospice patients die at home, where the family is administering the morphine that is legally prescribed under hospice, that is prescribed in dosages that continue to depress respiratory systems and cause death. People stop breathing due to the morphine that is administered by family members. We don't call that last person who administered the dose a murderer, but that's what happened. They caused the death. This is a case here where it's a self-administration. In hospice, people don't have the ability to even self-administer, and it's normally a family member that is prescribing that. We don't write on a death certificate morphine overdose. We write the diagnosis that got you into hospice. So in essence, many of the provisions in your bill are more restrictive than what has been allowed for the last 42 years in Illinois. So all of our proponents, and what I heard in their testimony, support hospice care. I'm not understanding, and really this isn't a question, it's more of a statement. I don't see what the reluctance is to offer people this option as well. Thank you.
Go ahead.
Thank you. I'd be happy to speak on this. On a personal note, because I know we've talked about capacity, depression, suicidal tendencies. I have struggled personally with depression. And I found myself that I was very good at hiding it from physicians, from individuals, from my own family. And we've seen this time and time again, where it's it can be very difficult to understand and know when a family member does have depression, right? It's often that, hey, I never expected, my family member to commit suicide, right? I never saw the signs. So in terms of determining capacity and whether depression is factored into that, again, that there are individuals who do a very good job of actually hiding that depression from those who are even as close as they possibly can be to that individual, right? Your comment on hospice care, the difference between getting a mental health referral for hospice care in comparison to a bill like this is that the bill itself is ending a life. Hospice care itself is not ending somebody's life. This may be the end stages of that life in ensuring, right, that they are able to end their last 6 months of their life in a comfortable fashion, in a way that is as pain-free as physically possible. But understanding that, in essence, that I can go and I can be facing depression. I could have received a denial letter, very similarly that we have these pieces of the bill in terms of insurance provisions that are present within the state of California. That we've seen by the testimony of Dr. Callister that individuals have been denied coverage but offered physician-assisted suicide. So I can receive a denial letter, and I now know that, look, that this last-ditch effort, this last form of treatment that may have elongated my life is no longer available to me, but physician-assisted suicide is available to me. And now I must deal with the fact that I'm in a place where I know that I am going to die because I may not have the financial means to actually receive that care. And I just want to also touch on is that hospice care is also not available to everyone in the state of Illinois. That right now we're on the precipice of potentially losing Medicaid expansion, which would cause over 700,000 Illinois residents to lose Medicaid coverage, and that includes hospice care. From the example that I talked about earlier in my testimony, that IDOC does not have a functioning hospice care system. They have a hospice care unit, which is a misnomer, because currently there are only incarcerated individuals that are staffing that program, but the women's side of IDOC does not have any hospice care whatsoever. So there are plenty of individuals in the state of Illinois that do not have access to these services to begin with. And again, that providing this option in lieu of, in some of these instances, in lieu of hospice care, is that really a choice? In the sense in the IDOC that your two choices are either dying in your cell or utilizing physician-assisted suicide. And to me, that's not a choice.
Mr. Chairman, I just want to state that the definition of hospice is, of course, it's aid in dying in dignity manner. But also, the DSM guidelines, which are the diagnosis codes that we're able to bill for, does not list depression as a terminal illness.
Because the
Anderson?
depression wouldn't matter if you didn't have a diagnosis of less than 6 months to live. So the depression is irrelevant. You still have to have that diagnosis of having less than 6 months to live.
I have to let the committee know you're hearing some things that are simply untrue now. Depression does matter. And for the record, I do mental capacity exams all the time on a routine basis. In Oregon, and I have that data because it's 20 years, the last data was not less than 4%. It was 2.5% were referred for capacity exams. That's it. I also need to add that the DDMA PH, which Dr. Barnard mentioned that they're giving now with the phenobarbital and all these other concoctions, have never been studied in a medical literature peer-reviewed study that was published in a journal. Every one of these concoctions has been made up and expanded on over the last 20 years. They are not FDA approved for the use in killing someone. And this is a concoction of 4 to 5 drugs at once that has not been studied. Compassion Choices will say they have research. Their research is literally their physicians experimenting with different drug concoctions. You need to know that that's the case. As far as people who have taken the pills, in Oregon's most recent data, 60 people received the pills, and this came out, this is public. 60 people received the pills for a diagnosis of other. 437 for endocrine disorders, which are diabetes, thyroid. This is something that, can't be swept under the rug. As far as the reasons people presented and asked for the pills, in the last Oregon publication, which goes through 2024,
Dr. Callister?
economy, 90%, losing
Dr. Callister?
80%.
Dr. Callister, thanks for your testimony. If you can wait till you're asked a question by a committee member, we'd appreciate that. Senator Anderson is recognized.
At this point,
Thank you.
so
I start off, I do have a question, and I think it'd be interesting because I'm going to have the same question for both doctors here, and I think it'd be interesting because there's one proponent, one opponent, one that's in the field and one that is not practicing in the aid of dying field. Dr. Callister, I'll ask you first. Does doing this, aid in dying, does it violate the Hippocratic Oath of do no harm?
absolutely it does. And in fact, most medical schools are not administering the Hippocratic Oath anymore. They're administering different watered down versions. And the reason I say it violates the Hippocratic Oath is because having someone die in their own time with your assistance when they may not be medically ready to die, meaning they have potentially good quality time left. Again, I looked at the Oregon data, 33% of the people, not 40 in the latest release, took the pills in the year they were prescribed. 33%, that's it.
Thanks.
So,
Yeah, thank you. And then Dr. Barnard, if you could answer the same question, do you feel that doing this practice, doing this work, violates your Hippocratic Oath of do no harm?
I do not. I will say that the Hippocratic Oath is a very, very old document, and if you pull it up, it was good for its time, but it also includes things like you should not charge money for your services. You should not operate on a patient because at the time—
I was specifically talking about the do no harm part.
The do no harm has changed over years. For example, in the 1970s, when we had debates about whether or not if you started life support and placed somebody on a ventilator in hopes that you could get them through, and then they looked like they were dying and they were not going to survive, we had robust debates about, was it right and okay to liberate that person from the ventilator and let them die? In the 1980s, we had similar discussions around the use of artificial nutrition and the concept of what is harm and what is right based on an individual patient. So I feel like do no harm is something that has evolved over time, just like the rest of medical care, and is much more complicated and nuanced when you're sitting in front of a patient and actually talking about what's important to them.
I'd also like to add that the claim that CNC is experimenting or using our doctors to experiment on patients, that's completely false.
Okay, Senator, I want to add something to something, and maybe it was answered and I just missed it, but a line of questioning that Senator Tracy asked before about the prescriptions, the prescribed meds and the death certificate and how it's used, and you were pointing to the data that says it's logged after when a doc prescribes it, but that's not necessarily saying that the patient used it. So I guess I want to know is, do we have data that shows that not just what patients were prescribed it, but if they actually used it?
Yes. Yes, we do, which is how we come up with the number of knowing that 37% of the people that get it don't take it.
Sure, and how do we know that? How do we get that data? I guess that's what I'm after.
So, hi, a little game of musical chairs.
Yeah.
So there's utilization reports in almost every single state that has authorized medical aid in dying. I'd be happy to send that over to you if you're interested. But yeah, that's how we're
How do
able
we
to
get
determine.
that, though?
Every single person who requests a prescription for medical aid in dying, that's documented.
Yes, but whether they use it or not, that's what I'm getting at.
That's also documented.
How is it documented?
Well,
Who documents it?
I'm not in the room with them.
That's what I'm getting at. Is how do we know that data?
Yeah, so I think, so if you look at page 28 of the amendment, it talks about what's required for the data collection. One component is the number of prescriptions for medication written pursuant to the Act,
Yep.
And then the number of qualified patients who died following self-administration of the medication prescribed. So you get the number who asked and then the number who actually used it. Does that answer your question?
No, I'm
Okay.
asking how we get that data. How do we know they used it? That's what I'm asking. We know they're prescribed it, right?
Yeah.
How do we know if they're using it or if they just died of natural causes? That's what I'm asking.
So I'm sorry, you're asking like how do they fill out the form? So how do you know that I got the prescription and
No.
I actually used it versus not using it at all?
That's correct. How do we know? We know the doctors prescribe it. That data is easy to find. What I'm asking is when a patient dies, how do we know they died from taking the med prescribed, or if they just died of natural causes and that med is still in the fridge?
Got it. And maybe I can ask Dr. Barnard, since she's a practitioner in the
Sure.
state, how
Yeah.
that's played out. Dr. Barnard?
In Vermont, part of our mandatory requirements for reporting is what's called a physician follow-up form, where it asks you for information about the manner in which the patient died and if medications were used.
Okay, but that may be how you do it in Vermont, but in this piece of legislation, there does not have to be a medical professional there when it is administered, because it's self-administered. How do we know? Again, how do we know that they took it or they just died of natural causes?
Or someone gave it to them.
I guess I might be a little confused about the need for or the purpose of you asking that question.
Perfect. Yeah, I'm
because
happy you asked that, because back to Senator Tracy's question about data, and I'm assuming, unless we're making numbers up, as Senator Holmes stated, that we know that 37% of people that are prescribed don't use it. Is that correct?
Yes.
How do we get that 37% if we don't know if they used it or not? That's the data I'm trying to get at. So either we know 37% don't use it, somehow we're logging that data, or we're making 37% up.
So there's a component of the bill, I think it's section 60, around the data collection that says within 60 days of notification of a qualified patient's death from self-administration of the medication, the physician shall submit to the attending to the department an attending physician follow-up. So that's where the physician essentially calls or reaches out to figure out whether or not the medication was used. There's also language around self-disposal of medication. So I guess if there's a concern that there is the drug that's still in the home, there's a requirement that disposal happens.
Yeah.
So-
Yeah.
And mind you, they've got a lot of drugs to dispose, because even before this, I mean, when I think of even with my mom, the number of painkillers you have even on hand. So, I mean, you've
Sure.
got all those drugs that you do want to make sure are properly disposed of.
Yeah, and I guess we're getting to my next concern here, but we still haven't answered how we know, other than the doctor somehow maybe talked to family and said, "Oh yeah, she took it." My concern is what if the patient dies of natural causes and family takes the med, like takes it with them to do something nefarious?
I guess you don't, but I mean, quite honestly, in this case, the odds of that happening, but again, you don't know when they're at home in hospice care and you've got access to giving them morphine.
Well, sure you do, because you have a nurse there during
Uh-uh.
hospice.
Yeah,
No. That's right. But I'm saying, how do we know that? How do we know that they've taken it?
And I would say, and I'd be interested to hear, but in most cases, people that are doing this process, they are still doing follow-up with the doctors. They are talking to doctors. And most people that are taking these drugs are not doing it when they are home alone. There's usually a family member who is with them. I mean, because most of us don't really want to die alone. We want a family member with us.
Okay.
So
So
you're trusting that, yes, the family's going to say, we didn't use it, here's the drugs, I'm going to dispose of them in the manner I should, like I do with every single other drug that was left on hand by this patient that's been taking drugs for months.
That's
And
all
I'm
I was
gonna
trying.
dispose
That's
of
all I was
them.
trying to get answered. Is
Anybody-
how do we know? If we're relying on family to say, okay, that's fine. I appreciate that. That's all I was trying to get at.
Well, and the
Yeah.
reporting requirements, of course, so I mean, yes, but again, those reporting requirements are coming because the
there's-
family is giving them the data to do the reporting.
There's
Because
no
they've gotta follow.
regulation for the legal disposal of these lethal concoctions. No regulation at all.
Senator, if there's I'll throw out a scenario. Somebody is terminal because of cirrhosis of the liver, and they get put on. They're terminal unless they get a transplant, and they're on the transplant list, but they don't want the transplant. They just want to die. Can they go ahead and get this done? The aid in dying, even though they could be cured with a transplant.
Well, I think I'll have Dr. Barnard address this, but I will also say one thing that even if they get a transplant, it doesn't mean they would be cured. I mean, their body could reject the transplant, they would die anyway. So, I mean, we definitely don't know that they'll be cured from a transplant. I mean, we know it's an option.
Oh, I mean, we don't know if we'll be cured of anything.
Right.
Yeah, so does that mean anybody can do this?
For what reason?
It's exactly.
You still have to, I mean, they're still being told if they have cirrhosis of the liver and the liver is at such a point that they need a transplant, it's not like they're just anybody out there like any of us right now deciding that, oh, gee, we can do this. That doesn't make sense. You've still got a terminal diagnosis.
Yeah. So you're terminal, you're on the transplant list. They say, hey, we got a transplant, and the person says, nope, I'm just going to take the med. That's cool. We can do that.
I don't even know.
They're terminal.
We can have Dr. Barnard answer, and then I can follow up if that's okay.
Sure.
With you. Thanks.
In order to begin the process of medical aid in dying, one has to have a terminal illness with a prognosis of less than 6 months. It is not uncommon, because people want to live, for them to sometimes want to pursue parallel tracks. For example, a patient with, say, pancreatic cancer pursuing experimental fourth-line chemotherapy. At the same time, the truth is, even though there's a small chance that they could live through that chemotherapy, there's a greater than 50% chance that they are going to die within 6 months, and therefore they're eligible for hospice. And if they choose to, they would be eligible to begin the process of medical aid in dying. So your example of a liver transplant is a little complicated, because getting a transplant is so risky and is very, very complicated. It is a patient's individual choice to know what their treatment options are and be fully informed about what those treatments are, and to have the option of choosing what treatment is right for them. And every patient makes different decisions. Some people would go for that transplant and a 2% chance of living with fourth-line chemotherapy. Other people make different choices. It's really about respecting individuals and their right to make fully informed choices.
And Leader Anderson, I think sorry, Minority Spokesperson Anderson, I think part of why we care about this issue is around bodily autonomy, so that people could choose or whether or not they want to do some kind of treatment. So in the same way, if somebody, a clinical trial opened up and they've decided, I don't want to go through another round of chemotherapy or some other kind of care, and they can say no to it, and then they could use this option instead. In the same way, they could decide to go to hospice care instead. So that would be the additional thing I'd add to your question.
In the case of a transplant too, you've also got it's very sometimes difficult to even find the organs that you need. So, I mean, they may not even really have that option.
Yeah. No, no, I understand there's scenarios. I was just giving the one that, maybe could happen. Where and why did we settle on 6 months?
We coordinated that with the hospice, because that's about when you have that 6 months left to live, that you have the ability to go into hospice.
Okay. And what is the difference, if there is a difference, outside of the subjective terminal diagnosis? What is the difference between this and suicide?
So you're asking why this isn't suicide? Well, number one, you have a diagnosis that you have 6 months or less to live.
So
So
that's the only difference, though? That's what I'm asking. Outside of the subjective terminal diagnosis, is there a difference between this and suicide?
Yes, there absolutely is. And let me read you, hold on, or you want to hit it while I look up what I want to look up?
Oh, I was saying that part of the definition of like the prognosis is that the person is, there is no hope for improvement of health. So I think if somebody is suicidal, it's not like they are going to die soon or they have some kind of health issue that would, the end result is death. So even if you are, your prognosis is 6 months, like Andrew, I think Susie was lucky that he was able to live longer because of interventions. At the end of the day, he was going to die. I think just thinking about Deb, who is dealing with her bone cancer is now spread to her brain. She's tried everything possible. She knows she's going to die. It's a matter of slowing down when that happens. For somebody who is dealing with suicidal tendencies or wants to commit suicide, it's a different circumstance in that scenario.
Yeah, well, I guess that's what I'm trying to get to the root of, because, I mean, we're all going to die. Like, we're all terminal. The moment we're born, we're terminal.
Right, but it's
Right.
also, one other
So-
thing is
okay.
the American Academy of Hospice and Palliative Medicine, American College of Legal Medicine, American Medical Women's Association, all of these say that this is physician aid in dying the way it is done. This is a peer-reviewed clinical. This is not suicide. So I think you've got all kinds of peer-reviewed stuff where doctors have understood it. So it's
No,
you're
but
still yes, you're choosing to die a week or two earlier than your illness would have had you die.
Well, I mean, not necessarily a week or two. I mean, if you got 6 months to live and they prescribe it to you and you decide to take it day one, then it's 6 months.
But we do have the data that shows that that's not the typical way of taking it. Most patients take it at the pretty much the very end stage,
Yeah,
which they
most.
get pretty good at knowing when you're at that end stage. I know this with my mother. They tell you the signs you watch for when you know that death is probably imminent within a week or two. And doctors are very good at doing that. They've seen a lot of people die.
Yeah, well, I've seen a lot of doctors be wrong too. I mean, you can't tell me that there's not a scenario where somebody was given 6 months to live and all of a sudden they've 10 years
No,
down
as a
the
matter
road.
of fact, we talk about Deb, who this bill is named after. She should have been gone several months ago
Yeah, thank God she didn't take it.
because she wasn't ready yet to take it, because she was still willing and wanting to fight for it,
Yeah,
which
With
is
you.
the choice. She had that choice.
yeah.
And she chose. She's choosing to go through another experimental process that could leave her desperately ill, but she wants to live, so she's trying everything she can.
Sure. So
Which is what most people do.
I'll end with this. So we talked. You mentioned a lot about people suffering and dying on their own terms. If somebody is diagnosed with a terminal illness, they're going to die, according to a physician, within 6 months. Do they have to be suffering to be prescribed this? No. Okay. So suffering doesn't play into this. I have a terminal illness and I feel completely fine, but here in the next 6 months I'm going to die, and I can just take it whenever I want.
What the law says and what it follows other states is somebody is terminal. It is not treatable. They will not be cured. When they choose to take it is up to them.
Got it. Thank you.
Senator Resin for a quick follow-up question.
Always quick. Thank you, Mr. Chairman. So going back to the data collection, the data collection in here. So it states in here all of the different data that you'll collect, but the point I was getting to is the data is collected by the Department of, what department collects it? Public Health, but it's confidential. So how is that collecting that data beneficial for people on the outside who want to analyze it and look at it and be able to see what's going on when this data you're collecting is only available to the people within the Department of Public Health?
And you should know this. There's all kinds of data that doctors and hospitals have that is confidential because you protect the patient. So you
No,
don't want to
I get it. It's
identify the
HIPAA.
patient. The actual medical data, it's just not identified as to who.
But is that data that's collected that is outside of the HIPAA collection available to more people than the Department of Public Health?
So there is the, on E, there is the department creating that and post public statistical report of non-identifying information with all of those subpoints in it.
And that's
If you're-
available to the public?
Yeah,
Okay.
Yeah.
Thank you.
Any other committee members with questions? Seeing none, Senator Holmes, do you wish to provide a closing statement?
Yes, I'd like to talk to for several more minutes. No, you know what I really want to do? I want to thank Susie. I want to thank all of the people, whether proponents or opponents, who came and testified. And I want to thank you as a committee for taking the time to take this as seriously as it is and ask all the tough questions, because I just think it's so important. And I'm going to end basically with what I started with, is I would never urge somebody to do this if they didn't want, but don't take this choice away from me, because if I'm going to be diagnosed with cancer and be dying an extremely painful death, I would like to have this as an option. And that is the feelings of more than 70% of the population, not just in the research study by Impact Research. We ourselves as a caucus have also done the research, and those numbers are pretty similar across the board. So I would ask for your thoughtful support of this, and I appreciate all the questions and all the input.
Thank you. The roll is open. Please continue, Clerk.
Senator Tracy, Senator Resin, Leader Curran, Senator Anderson, Senator Kaler, Senator Murphy, Senator Lightford, Senator Holmes, Senator Harris, President Harmon, Senator Cunningham.
With 8 senators voting in the affirmative and 3 voting no, the bill passes and shall be reported to the floor. Thank you, Senator Holmes.